So let me just start off with a few questions that I got so far. Federico, you have been, showing data on people on a basal insulin, and someone is asking if you have any uh, top tip to how to use, how to really the data generated by the continuous glucose monitoring to adjust the therapy in your type 2 diabetic individuals.
My suggestion regard the empowerment of the patient to the auto management of his diet. I remember a study of a couple of years ago, the Seoul protocol. The patient look at a postprandial glycemic profile and say, the food is non-healthy, I have to avoid the food. The food is healthy, I have to reduce the amount of food. So FGM is very important for the education of the patient to learn much better to manage his diet, to manage much better the selection of the food. Is of course important also for the physician, but the role in type 2 of this system is particularly for the education of the patient.
Thank you, Federico. Yvonne, I also have a question for you coming from the audience. Is statistical data from trials enough to change professional behavior of healthcare providers regarding if they adopt the recommending of Libre and the Novo 6 systems? In other words, do you see the data currently available strong enough to really start delivering it?
Well, actually, since we have these implementations, I started my first people with diabetes 2.5 years ago. So this is a really novel innovation. And I think the data from the scientific literature is not enough to support it in a guideline, but I hope that we will have that soon within the coming years.
I think probably needed to gain experience on that and also to digest it and to learn how really get the best out of it, huh?
Yes, and I guess we have to get the clinical experience in order to set the questions for the trials,
Yeah.
because we should know what we want to answer.
Right. Also have a question for Emma. Could you provide practical suggestion for managing AID during labor and after delivery? So this is a very clinical question. You got
Yes.
the tool, how you want to use the tool?
Yeah, so we use CAMI PS in the UK, which was used in the ADAPT trial, and we can very confidently continue that through the labour process and just set a higher target so that when you get that sudden reduction in insulin requirements as the baby's delivered, the system will protect against hypoglycemia just when you set a higher target, and it will adjust for this change in requirements. And it just makes the whole transition from labour into that post-delivery phase far less stressful for us as healthcare professionals and also the women living with diabetes. So very positive experiences overall.
And now I have a question here that I've been considering provocative till a short time ago. And I'm sort of, offering this on a silver plate to my friend Tadei, but I also like to have the opinion of all the other speakers. And the question is a very simple one. Do you suggest the use of CGM for all type 2 diabetic people?
Do I have to speak up? I think, the basic thing that's important is that glucose is dangerous. Glucose is dangerous. A recent study that published glucose data on 12,000 healthy young individuals demonstrated that females have a lower normal glucose. Is this the reason why we have a higher mortality in females in type 1 diabetes? Because we use the same target. Is this why, the glucose during pregnancy is lower? Because it protects the fetal brain. So glucose is dangerous. So if we have a method to visualize glucose and act early enough to prevent the damage, this is what we should do. I'm listening to these lectures when a person has kidney failure and heart failure, I don't know what failure, and then this person is eligible for CGM and for medicines. It is 20 years too late. I would love to see the person on CGM, but the first glucose elevation was detected. And this is the good time to start disease-modifying medications. and to monitor continuously to know that the person has normal glucose, perhaps even with a gender-specific target for the glucose. Happy International Women's Day again.
Today, women have lower glucose. You are implying something that I'm not going to agree with, that men are sweeter than ladies. All right, which cannot be, and I don't buy it. Don't buy it for sure. All right, but as I said, I also like to hear in the opinion of our other distinguished speaker.
Yeah, so I think we need to be quite honest here. 10 years from now, nobody is going to be finger pricking. It's just a matter of time until we get there. We're seeing more and more trials coming through supporting this. There's a systematic review and meta-analysis that was literally just published that showed improvements in time and range and HbA1c in people with type 2 diabetes, and the benefits were the same whether you were treated with insulin or not. So I think we're getting there. The trials are ongoing, but in my mind, this is where we'll end up. It's a matter of when rather than if.
Yvonne.
Yeah, actually, have to be honest. We see the data that CGM application reduce HbA1c by 0.45 up to 1%, and that's what some glucose lowering agents do, who all get reimbursed. So I think that has the same power, but the power I see is especially in adapting lifestyle behavior, because it's so great for the people to see what exercise and food does to their blood glucose. And sometimes they have such a feeling of success if they have high glucose, just take a walk for 30 to 45 minutes and come back and immediately see that it changes their glucose, that it's now normal, and they were responsible for that. And I think that's a great issue in learning.
And Federico, in the Lombardy, you succeeded to get reimbursement for people with type 2 diabetes on insulin and even on oral glucose agents. So would you expect then the Lombardy to get and provide the CGM for all type 2 diabetic individuals?
Okay. Yes, it's yeah, I hope to have these results of these changes. The initial experience is extremely positive. The patient is really involved in the management of his therapy. So I think that this possibility, the possibility of have a continuous information about their glucose profile is strategic for achieving the better glucose controls in the cohort of a population.
I'm a strong believer, that action should be data driven. So, if you don't have the data, you just go by blind. All right. So I think that, that could be something that we can keep in mind. We are coming to the hour. We are coming to the end of this symposium. I hope that you can have found it informative and not just to provide you with a solution, but rather to provide you with some food for thought. And I think there are a number of things that we have to think about. One final thing that we need to think about after, having thanked Abbott for having given us this opportunity to discuss the data and TTD to host this symposium, is that in the field of diabetes, the tools that were enhanced are incredibly increasing. Pharmacologically, in terms of delivering of the treatment, and also in terms of the monitoring the treatment. So we have the tools. It's up to us to make it work. Thank you very much for being with us today.